Welcome to the Dutch Podcast, where we dive deep into the science of hormones, wellness, and personalized healthcare. I'm Dr. Jacqueline Smeaton, Chief Medical Officer at Dutch. Join us every Tuesday as we bring you expert insights, cutting-edge research, and practical tips to help you take control of your health from the inside out. Whether you're a healthcare professional or simply looking to optimize your own well-being, we've got you covered. The contents of this podcast are for educational and informational purposes only. The information is not to be interpreted as or mistaken for medical advice. Consult your healthcare provider for medical advice, diagnosis, or treatment. On today's episode of the Dutch Podcast, we get to talk about the most popular topic that's coming up at Dutch lately, which is perimenopause. And not only that, I get the chance to speak with one of my very favorite just human beings generally, a mentor of mine and one of the most experienced teachers and clinicians in our field for women's health. In fact, I think she might have been the first doctor out there to specialize in women's health in integrative medicine, Dr. Tori Hudson. Before I share a bit about Dr. Hudson, I want to just talk a little bit about this topic and why it's something that we really felt passionate about covering on the podcast. Now, perimenopause, of course, is this window of time before the end of a woman's menstrual cycle. And if it was that straightforward, it would be really boring to talk about. But there's so many changes that come up during this time. One, because the ovaries have this intermittent function as they near the end of their functional life, but also because there's so many additional symptoms that can come up during this time. It's also a time where a lot of women go through other health changes and other concerns crop up, like metabolic health, cardiovascular health, weight gain, brain fog, mood changes, and things that could be related to perimenopausal hormone change or could be completely unrelated to it. And it makes it a particularly tricky time for us to treat as clinicians. But it's a time that's also so important to get right for women. Now, Dr. Hudson is a respected naturopathic physician with a deep passion for women's health, especially across gynecology and endocrinology. She's nationally recognized because she has a thoughtful and true integrative approach to menopause and perimenopause, really combining the best of naturopathic principles with conventional research to support and guide her patients. She's currently an adjunct clinical professor at NUNM, at Sonoran University of Health Sciences, Canadian College of Naturopathic Medicine, and Bastyr University, as well as the medical director at her clinic, A Women's Time. I think you're going to find in today's episode a lot of learnings. We talk about lifestyle changes. We talk about herbs and supplements. When we even talk about the use of hormones during perimenopause and menopause, we are lucky to get to tap into Dr. Hudson's expertise today. So let's go ahead and get started. Well, Tori, I'm so excited to have you here. I always love talking with you and feel really grateful that you're spending time with me today on the podcast.
Absolutely. Yes, I'm happy to see you as well.
So today we're going to talk about a topic that there are so many questions about and so much kind of uncertainty that women come in to see their provider with. But before we do that, I always love to ask, and I think I've heard this a little bit from you, but our listeners probably haven't. Tell me a little bit more about your backstory and what drew you to this work with women and with menopause and with perimenopause, because you've got an interesting backstory of how you became a naturopathic doctor and really developed. You were the first women's health specialist, I think, in our integrative medicine field, really.
I think that's true. Well, I don't know which backstory you want, but I am 73, and I have been thinking about menopause. So I was born in 1952. I have been thinking about menopause since 1964, November 24th, 2 p.m.
You know exactly.
And I was like, okay, when will this end? This experience of the menstrual cycle. So, I mean, that's, of course, funny, but it's true. And then fast forward in my career. So I started being a naturopathic physician in 1984. And it was really early in my career. And, I don't know, certainly within the first 5 years, where women it was my patients, and it was largely my menopause patients who were uh, transformed my thinking about, oh, integrative medicine is what I need to be knowing here. I need to know the medicines they're on. I need to know the options that exist. I need to know how to talk about those medicines, natural medicines, how they work together, how they don't work together, when, why, what, where, for. So they menopausal women were really the change agent for me, and my thinking, and how to meet their needs. And uh, I opened this clinic with my sister about 30 years ago, and it's called A Woman's Time Menopause Options. And at the time, I thought, well, if we just say menopause options on the sign, will that mean I'm only going to see menopausal women for menopausal issues? That did not happen. It's all comers, all ages, but as you know, I mean, perimenopausal, menopausal women, they don't just have perimenopause and menopause blatant issues. They have hypertension, they have fibromyalgia, they have Crohn's disease. I mean, they have all kinds of things, just like everybody else. So it ends up being really primary care for women with an emphasis on, gynecological endocrine issues.
Yeah, I mean, this is a really good place to start, because I think that people think about menopausal care or perimenopausal care as like hot flash management, right? That's what comes to mind for everyone. However, this I think a great place to start is like, this is a time of life where other things start to creep up, right? Autoimmune conditions, thyroid dysfunction, the impact of chronic stress, cardiovascular health, metabolic health, where you see the cumulative sum of behaviors that have been going on all of life, and then you add to the mix some of the things that it can be instigated by hormonal change, like sleep disruption, the hot flashes, sexual changes. I mean, mood changes. We can name. I want to talk about all these with you, but
yes,
I like the way you kind of flip the script, where it's not just about treating the hormones; it's about treating the whole person. And I'd love for you to share a little bit more about that, because as a women's health clinic, you do a lot of primary care. And is that a surprise to your patients, the approach that you take when they come in the door? Do you give them what they're expecting, or do you give them more or something different?
I think it's mixed. I think, let's say a perimenopausal woman does come in for her cycle irregularity and her, well, first of all, she might not know it's perimenopause, and we might not know until we talk more. But let's say she's having, now menstrual irregularity and vasomotor symptoms. And then, of course, I am going to go through the review of systems and, as much about her health as we can accomplish in that visit. And she might surprisedly learn that, oh, I can help her with her blood pressure, and help her with her asthma, and help her with, you name it. But other people, they're like, oh wow, here's a doctor I've read about the clinic, read about naturopathic medicine. I could do everything I need there. And then they come for everything they need here, and they transfer, their care. I become the person that's doing their exams, maybe prescribing medication that they are on and they do need. And then we can, of course, entertain the idea of, are there alternatives, or are there options? So women don't just come here for botanical or hormonal treatment. But certainly if they are in the perimenopause menopause window, then they are usually aware that there's hormone options and there's non-hormone options.
Yeah, and one thing that I've always admired about you, and I'll share my first time interacting with you. I won't share the second, because it didn't turn out so well for me.
It did turn out extremely well for you.
In the end, it did. But I'll share that story in a minute too, just for listeners, so we don't keep them out of the loop. But the first time I ever met you, was when you came in to guest lecture in my gynecology class at Bastyr, and you were speaking to the biases that a lot of naturopathic doctors graduated with, which was like anti-oral contraceptive pills.
Oh, yeah.
And I'll never, honestly, like, it's fun that this still sticks with me 20-ish something years later, that I remember that exact moment because it was, it was shocking. It was different from what I'd been hearing from my professors, first of all, not necessarily targeted towards oral contraceptives, but I think there was a general bias that like naturopathic medicine was superior to conventional therapies. And you really were very in our face about the fact that these medicines, oral contraceptives specifically, had a really specific purpose and use and utility clinically, and that, like, who were we to basically reverse feminism and tell women these were bad when they could be really a huge life changer. But I bring that up not to talk about oral contraceptives, but because it speaks to your perspective. And I think that still carries out in everything that you teach and everything that I've learned from you, which is we're here to help our patients. We're lucky as naturopathic doctors. We have lifestyle tools, we have herbs, we have nutrients, and we have pharmaceutical drugs that can be prescribed. And we should be using the best tool for the patient always. And that's one thing I really admire is you come forward with all options, like truly in that supported decision-making process for a patient, really with a lot less bias than a lot of practitioners.
Well, thank you. I appreciate you noting that and acknowledging that about me. And like I said, it was really patience that transformed me, because at one time I was, I was a rigid fruitarian, for God's sakes. You can't get too much more rigid than that. And thankfully, I'm sort of anti-fundamentalism thinking on all areas of life and the world at large. And I think there is fundamentalist thinking about medicine exists, whether that's fundamentalism conventional only or fundamentalism natural only. And I really take to heart one of our principles, which was treat the whole. And to me, you can't just treat the whole separate from the whole. Treat the whole is the whole in a large view on the whole.
Yeah, absolutely. The second time, just because I know I'm going to be asked about this, that I met Tori was when I interviewed for this coveted women's health residency at our clinic, which there was one space for the whole profession. And I did make it through to the interview phase and traveled to Portland and really felt this like great connection with Tori. I walked away feeling so great about the interview, but I didn't get it. But it all works out in the end because now Tori and I get to work together.
And we work together. Yeah. I have, without disparaging the person that I did pick, because we're good colleagues and good friends, but it's a regret. Like, dang, I could have had Jacqueline and we could have done this. We could have done that.
But honestly, like, truly you've mentored so many clinicians and still have residents, and it's been a big part of your career, which has been awesome. And you've mentored me in countless ways since then. I've been really blessed, even though I didn't get the residency. I feel like I've gotten to like soak in a lot of your experience because
we've enjoyed learning from each other this last year in particular.
Absolutely.
I think. Yeah.
So I want to talk a little bit more about perimenopause and. I find it so interesting because perimenopause used to feel like this kind of black box time for women. Of course, it's like anywhere from 2 to 10 years, right? Before menopause, before the final menstrual period.
I think the number they really identify, it could be 2, but I think the number that's printed is sort of 4 to 8 years.
4 to 8. Okay. Yeah. Can you share a little bit about what's happening hormonally and physiologically during that time?
Well, as every organ ages, and so does the ovaries. So do the ovaries, and so there are less and less follicles, and thus less estrogen, less ovulations, and ultimately very low estrogen and very low progesterone, and lowish testosterone. But so that that's just that whole feedback loop, hypothalamus, pituitary, ovaries, it goes through a normal change process. And that's why I don't really like to use the word hormonal imbalance, because it's balanced for the time that it's supposed to be. It's supposed to be changing. It's supposed to be irregular. It's supposed to be erratic. It's supposed to be higher FSH, lower estradiol, etc. It's how, but so while that's normal and natural, I'm not trying to change that. I'm trying to change how, if it's happening at a normal age time period. What we're trying to change is, how does the person adapting to that? What are the quality of life issues she's struggling with as a result of that? And so to me, the focus should be on that, not that her hormones are imbalanced. It's that, what are the manifestations of that for her? And
What are the
sometimes we do need hormones
Yeah.
to solve that.
What are the
What-
most common manifestations of it that you see in
Yeah.
your clinic?
Well, if we're talking about natural physiologic perimenopause and menopause, meaning someone who still has her ovaries, basically the strictest definition is a change in the menstrual cycle, from and it can get a little longer, it can get a little shorter, and and go back and forth, and then it can become a little heavier, or sometimes a lot heavier or lighter. But the first cue really is that regularity changes. I think that's the strictest definition, but I think we're at a time when we're stretching that, and because some women do have what I call these sneaker symptoms before the perceptible change in her cycle and her menses. So, but the strict definition is irregularity in the menstrual cycle and perhaps some change in the flow. And then the common symptoms are vasomotor symptoms, whether that's hot flashes and or night sweats. That's all vasomotor symptoms. And sleep disturbances and mood changes and vulvovaginal thinning, dryness changes. So those are the big five, the classic characteristic symptoms. But then there's a long list of other things that can be occurring, like the brain fog, the depression, the anxiety, the fatigue, the low libido, hair thinning, facial hair, body aches, fatigue, if I didn't mention that already. What's confusing, what can be complicated is many of those symptoms can be due to other causes. So, and then women right now, especially in perimenopause, and especially with the sort of hiked up awareness and conversation and information sharing, sort of like if you're in your 40s, if you have any symptom, she's thinking, oh, it's perimenopause. And that's not going to be true. Not every symptom is related to perimenopause. And certainly there is great variability in how women experience perimenopause and menopause. I mean, for example, I'll just use myself. I mean, really, the only change I had was a change in my menstrual cycle. I was just one of those people that just lucked out. Um, but it can be mild symptoms, it can be severe symptoms, anything in between. Some can be temporary, intermittent. Some are long term. We talked about the years prior to the final menstrual period. Right now, they say, like I said, like 4 to 8 years. So if the average age of menopause is 52, then we're thinking, in your early to mid 40s you can start to have some symptoms. And it takes a astute, well-informed provider in good communication with an aware, sharing patient to figure that all out.
I'm really curious to get your perspective on something that you mentioned, which is like now women come in with symptoms assuming it's perimenopause.
Mm-hmm.
But if I think back when I first started in practice, maybe that's 20 years ago, it feels like it was the other way around. Women were coming in with perimenopausal and menopausal symptoms and had no clue
That's a great point.
that it was perimenopause, menopause. How has patient knowledge changed over time? And how has that influenced the way women seek help, or what kind of help they seek?
You're right on to point that out. I love that because it's true, and it's still the most blatant way that I am often aware of the earlier scenario, and still exists, is that women are having, symptoms. Their mood is changing. They're tired. They're not sleeping, and there might even be having some heat, and they're 42, 43, 44, 45, and their conventional doctor said, oh no, that's not menopause related. Here's your
Too soon.
antidepressant.
Here's your mommy's little helper, your
here's
benzos.
your sleep aid. I mean, it was the most common setup.
I was thinking about that a lot. It was like women were told that it was called like hysteria, right? The mental health symptoms that happen during that time, they were diagnosed with hysteria. And like,
if we go back further, then
I guess that's how even further.
If we go back further, that concept is why women's ovaries, they had hysterectomies.
Right.
But yeah, that is, I'd say that, the practitioner awareness and education has improved. And that in combination with women coming in and talking about what's going on, now we get, I think, closer to, this is assessing and treating the right problem. Not to say that, even if we diagnose perimenopause, you can still need a sleep aid, whether it's natural or pharmaceutical. You can still need a mood elevating agent, whether it's natural or pharmaceutical. But I always like to think of it as the core issue is if we say, yes, this is perimenopause. So the core issue, the foundation is addressing that aspect of the endocrine system. So that's like, in a house, is the foundation in good order? And then we might need to hang some new curtains and put some new paint on the wall and, fix the plumbing. But like all those things are on top of, we got to make sure the foundation of this house is okay. And that's why, and I think of that in herbal medicine. Okay, let's use this plant, and that plant for the actual perimenopause endocrine system, and then attach valerian or attach St. John's wort. And even when I use hormones, I think that way. But hormones can frankly cover, prescribing estrogen, let's talk about that, can cover, to be honest with you, a wider breadth of symptoms and a wider breadth of disease prevention as a single agent than any single herb or nutrient. And that's what makes it, a compelling therapy.
Well, let's divert a little bit and talk about estrogen therapy since you brought it up.
Okay.
And this is such an area of expertise for you. And I think one, historically, maybe you can talk just briefly about WHI and the impact that that's had on the women that you're seeing today in your practice. And so Women's Health Initiative, this study that came out in the early 2000s, really suggesting that estrogen replacement therapy was dangerous, had side effects, breast cancer, cardiovascular incidents, et cetera. And so most providers stopped prescribing it or significantly reduced their prescription. Now, like you said, we now know the clinical utility of estrogen. Can you just speak a little bit to that? And then I want to talk about estrogen and progesterone replacement, or not replacement, estrogen and progesterone therapy in perimenopause afterward. We can kind of shift to that a little bit.
Well, to make a long story short, before the Women's Health Initiative in 2002, so we had a good 40 plus years, something in that neighborhood, of menopausal hormone therapy was the recommendation whether you had a symptom or not. The primary indication was to reduce your risk of cardiovascular disease, and it was considered primary prevention for that purpose. And that was based on all observational research, no randomized controlled trial for several decades. And then something popped up called the HERS trial, which kind of like, maybe there's a little worrisome thing there about estrogen and strokes and such. And then the Women's Health Initiative. So the primary indication preventing heart disease, the WHI said, sorry, it's not doing that. In fact, it's increasing cardiovascular disease and increasing strokes and blood clots and ischemic heart disease, heart attacks, etc. And so that was like, whoa, we're talking decades of this, and then all of a sudden, the most major randomized controlled trial I think ever done on women for any issue at all historically. And so there was like, not only was it not shown to do what we thought we were doing all those several decades, then there was this fear about, oh my God, it's increasing the risk of breast cancer, which in the next 25 years we've learned is basically not true. So we kind of went with all women should go on hormones for this reason to no woman should go on hormones and she should stop. And now we're back to sort of stage one and then some. Now we're back to hormones are a superfood and all women should go on it. And I would pose that neither of these three eras is accurate. Like neither of the three pitches or conclusions is accurate. It shouldn't have been done to only prevent heart disease. It shouldn't have been automatically stopped. And it shouldn't be seen as a superfood solving all problems and all women should go on it forever again. So it's really, now we need to be nuanced and individualize the recommendation, individualize the evaluation, individualize the need for any testing, individualize the recommendations based on benefits and risk, which change over time as she ages. What my risk is for heart disease at 52 is different than at 73. So women know whether they go on hormones or not on hormones. The health issues change over time, and the conversation about benefits and risk of hormones needs to change over time.
Yeah, and the data is really evolving. We've talked about this on this podcast a lot, but for example, cognitive health, we're like early on in that data. We don't have clear conclusions. It's suggestive, it could be beneficial, but not for everyone and not all the time. But we have to be careful not to jump to conclusions too soon.
The one that I'm the most kind of like, the one that stands out for me to counter the superfood idea of estrogen, I think the most important thing to call out with that is right now there is a optimal window in which to initiate taking menopausal hormone therapies, which is before, if you're going to, for whatever the reasons, quality of life, disease prevention, disease treatment, it should be initiated either prior to age 60 or before she's gone 10 years from her last menstrual period. Because if we initiate beyond that, then we still, all the menopause societies around the world are still in sync that can increase her risk of cardiovascular disease and possibly Alzheimer's. And like you said, I think we're just like the whole Alzheimer's dementia thing is just like, we're getting to see that really unfold in live time, I think, right now.
Yeah.
But initiation is different than duration. So it doesn't mean we have to stop after age 60 or stop after 10 years. It has nothing to do with that. It has to do with initiation. And then duration is a different topic.
And that seems, just to kind of add a little bit of color to it, that seems it's because when you have a 10-year window of time without exposure to hormone, you have cellular change, right?
Yes.
That is a result of the changing hormonal landscape. And then to reintroduce estrogen, it behaves differently and the cells respond differently than they would if they had continuously been exposed. Did I explain that in a way that feels clear?
I think you did. And just to maybe kind of hone in on the vascular issue. So as an aging artery, it's stiffer, there's more plaque, there's the receptors age. And you're absolutely right. How that vessel responds to estrogen within that first 10 years or before age 60 is how it responds to estrogen is different than if you introduce it later. Because now that plaque, there's hard plaque, there's soft plaque, it's stiff, there's inflammation, the receptors don't respond the same to the estrogen. That's where and that's right now kind of what's largely true for the heart seems to be largely true for the brain, and I think that's a good way to think about it right now.
Yeah. Now that's interesting because that's talking about the latest point at which you should initiate hormone therapy. Really, with perimenopause, I think that's like another end of the spectrum to talk about, which is what's the earliest point when you should initiate hormone therapy.
Great question.
The interesting thing there is, associations don't provide clear guidance. It does seem gray. It's clear they agree you don't need to wait until 12 months after the last menstrual period. And one thing that I think is interesting is menopause technically is like the day that your last period ends. You just don't know it until 12 months later.
Yeah, right.
So already you have a gap like between truly diagnosing menopause and the cessation of your menses. There's a 1-year gap.
Yeah.
That could have been a time for hormone therapy. But when you and I want to talk about lifestyle factors and herbs and things as well today. But since we're talking about hormones, and this is the area people have the most questions about, when in perimenopause do you think it's time to start hormonal therapy when you're sitting with the patient? Of course, it's individualized. So what are the types of questions or signs that you'd look for that would tell you maybe this woman would benefit?
Well, I think the clearest guide for that population is what quality of life issues is she having that we think is related to the change in her hormones. So, and the more severe those issues are, the more likely we would need hormones rather than herbal and nutrient interventions or alone. We can always use a combination. So, for example, mild hot flashes, even moderate hot flashes, 4 night sweats, you can at least half of women will respond to good non-hormonal treatments. Good meaning, some standouts like black cohosh and maca and things like that. Or if she's, sleep issues. So the more severe, mild to moderate, I'm going to lean non-hormonal, non-pharmaceutical. Moderate to severe, I'm going to lean more hormonal. And then when push comes to shove, what is she thinking? And what is she partial to? Some women, I lay out all the options. We can do this, that, and that, and that. And we can start here, which is like hormones, and work our way down to something less intervention, or we can start here and work our way up. And some women want to start here and work their way up, and some women want to start there and work their way down, or start there and stay there. Often the conversation too involves helping them be less afraid of hormone prescriptions.
Are you still finding that you have a subset of women who are afraid?
Yes, I still have a subset of women who, especially if they have a family history of breast cancer, they think that they should not ever go on estrogen. And the research does not show that at all. Women who have even a mother or a sister with breast cancer, that is not a contraindication to go. Her going on menopausal hormone therapy does not add to the risk that she already has. And that seems counterintuitive, but research-wise, it's true. But also someone just philosophically, they have a philosophical paradigm, which is not unlike mine, that, I want to do something that more grows on the earth, or kind of like comes clearly from the earth than a pharmaceutical involving manufacturing and potential more side effects or nuisance effects.
Mm.
But it's also important to remind women the risk of breast cancer by going on estrogen plus a progestin starting at year 4 of taking it is, and then beyond, is ever so slight. It's not even one woman out of 1,000 women per year, which is less than, drinking too much alcohol, being obese, and being sedentary. Those are greater risks for breast cancer, especially the alcohol, than is menopausal hormone therapy. And if she doesn't have her uterus and she only goes on estrogen only, 20 plus years of data, estrogen doesn't increase her risk of breast cancer even to that 1 out of 1,000. So yes, I still have those conversations. And then other women are eager. They're 40. I just had a woman today. She was 42 and she had a set of symptoms and she's thinking that they're all perimenopause related. And as we talked more, she had, she has fatigue. She had iron deficiency anemia in the past. She's got a set of symptoms that look like it could be hypothyroid or it could look like iron deficiency. So, of course, you can have one or more of those things and be perimenopausal. So it's always important to remind you can have more than one thing. In fact, you likely have more than one thing going on at a time. The American College of OBGYNs, you mentioned it, what was the youngest age to start? Their point of view is still hormonal contraception. Prescribe birth control pills if they're having symptoms and irregular menses, because birth control pills solve the menstrual cycle stuff. They likely help some of her symptoms, and it provides contraception if she needs it. So it makes sense, but it doesn't make sense to say, oh, we should only do that and not do menopausal hormones. Birth control pills, have this much estrogen versus our menopausal estrogen.
Yeah, much more in an oral contraceptive.
Much more. So to me, any gynecologist who says, oh, no, you're too young to go on menopausal hormone therapy, to me, that's not accurate. It's not, it doesn't make sense that why overprescribe something? Why give something more than is needed?
I want to dive a little deeper into an area that you touched upon in a specific category or nuance. So you talked about, women thinking things are just perimenopause, but you need to also have on your differential diagnosis things that are not perimenopause or menopause kicking in. I want to talk about that more specifically with mental health, sleep, cognition. Because this is an area where I think women sometimes don't know where to turn, or they delay seeking help because they assume it's just perimenopause. Can you speak a little bit to how do you help patients, and when you do your trainings with practitioners, how do you help them differentiate between hormonal root cause versus others? And how do you think through, how should we be thinking through a more comprehensive approach to support women's mental health
in particular? Yeah, that can be on the list of sort of one of those sneaker symptoms. They're getting, or sneaker categories, getting more irritable, more short-tempered, a little more weepy, a little more stressed out, more easily, more anxious. No overt depression, no overt panic disorder. Well, it might not matter, frankly, to know, is this perimenopause or just stress, let's say. It can matter if she's got thyroid or anemia and stuff. But I think just the more questions you ask, and it might not be revealed in that first time. It's because perimenopause is changing, it's unfolding, it's unpredictable. But if she has any of those symptoms that you mentioned, and she has hot flashes and or night sweats, it's kind of like, oh, okay, that's pretty much a dead ringer for perimenopause. But if she doesn't have the vasomotor symptoms and she doesn't have a change in her menstrual cycle, is she having the very earliest phase of perimenopause? And I think many women are. but we might know better in retrospection, looking back, than we know right at that moment. But this is where you could do some kind of testing, but it's hard to, in perimenopause, it's hard to say, capture this moment on this day or these few days. Is that reflective of a bigger, does that answer the bigger question? And
Yeah.
I think it's a lot to expect. When it's abnormal, great. But when it's, but too often it's still normal. Those test results are still in the normal range. And that shouldn't discount that she's perimenopausal.
Mm-hmm.
I think for the practitioner and for the patient to know the full list of some of these symptoms that can occur is the starting point. How is what you're feeling now really different than your norm, than your usual? That's sort of the starting point of understanding, is it perimenopause or not?
And
would you say something different?
no, I mean, I think I really agree. I mean, the hormonal change, like you said, is a normal physiologic process.
Mm-hmm.
And we also know that things like PMS and PMDD are the result not always of hormone imbalance. I know you hate that word, but of, let's say, hormones being out of range. Sometimes and often they seem to be a abnormal response to the normal changes in
That's more
hormones.
what I would say.
And so when I think
particularly the neurotransmitters.
That's right. Neurotransmitters. So when I think about perimenopause, I think about the susceptibility of some women. I have not seen data on this. Maybe you have. But like women who have a history of PMS and PMDD, we know it actually can worsen during perimenopause, likely because your fluctuations are even bigger during that time. Estrogen can be higher than it is in your cycling years because you get, intermittent ovarian function. One of the docs I talked with called it like a ketchup bottle at the end, where you like shake the bottle and squeeze and nothing comes out, shake it and squeeze and nothing comes out. And then you shake it and squeeze and then all the ketchup comes out. And the ovaries are much like that in perimenopause. You can get, due to higher FSH levels trying to stimulate old follicles, if it catches a responsive follicle, the estradiol can be quite high. And then
that's actually called a loop cycle.
Cycle. That's right.
Actually a name for that. Yeah.
So I think, a lot of women can be more susceptible to the even greater fluctuations we see in perimenopause. And it's a consideration. And also, if the hormones are part of the issue, then sometimes hormone therapy or lifestyle therapy can help. And it, like you said, sometimes it doesn't matter. You need to figure out what's going to help that patient feel better.
I think also that might be important at this moment to say that women who have a history of anxiety and or depression in their past, that can have a increased likelihood of recurrence in perimenopause or early postmenopause. Women who have anxiety and or depression going into perimenopause can have an increase in the intensity of their symptoms in perimenopause or early year or two of postmenopause. So and that again, like we're saying, is that the hormone changes are normal, but the neurotransmitter, it's like the bath that the neurotransmitters, serotonin, dopamine, norepinephrine, the bath that they're used to being in, the bath water is different now. And so they're like more wobbly, and that affects so much about women's mood and sleep and even migraines.
Yeah. I mean, I also think about, related to mental health of women, for women during this age group, I think that it's really important to include in the conversation the fact that this is a really challenging time of life for a lot of women. Redefining maybe a career, or their kids moving out of the house, or parents aging.
Yes.
We live in societies where we're a lot more isolated as individuals. This is men and women too, right? That if you've not, because of the busyness of life, I feel like I'm having a therapy session. I'm speaking about this personally right now. With the busyness of life, it can be challenging to nurture those relationships that are really important to you. It's easy to get to feel isolated. And of course, that contributes to your mental health long term. So, I mean, it makes me think about, from a lifestyle perspective of what do we need to best support women through perimenopause, for me, the top of my list is relationships. When it comes to lifestyle factors, there's sleep, nutrition, movement, but I think relationships is an often missed piece of that puzzle for women. And I think about what's the reason why some women like you don't have any symptoms other than a change in their menstrual cycle. We see that also in tribal cultures. If you look at like medical anthropology studies, most tribal cultures like the Kung tribe and things that are heavily studied, they don't experience reports of symptoms. And it makes us think about, well, how do they view aging? How are women connected to their community? What's their purpose? So I think it's a complex issue that
totally complex, and how holistic and of you to really point out those big transitions that are happening in many women's life at that in their mid to late 40s, early 50s for sure. And there's also sort of a gut check, I think when you're 40, like, oh, this is like me. I might have less years ahead of me than I do behind me. And so there's a real motivational, I think there's a real opportunity to help women make changes and make choices and reevaluate their relationships. For some women, they need to get in deeper, more connected to certain people, and they need to get less connected, and out of in relationship with other people,
Oh yeah, I hear you there.
You mentioned tribal cultures. I have a very close friend who's a very traditional Navajo woman, and she asked her elder mother at one point, because when she started being in mid 40s, my friend asked her mother, well, I'm this and that is going on, and what do I do about this menopause thing that is happening? And her mother, who grew up even more traditional, was like, go chop more wood. It was like, this is no big deal. This is life. That has some value, but it shouldn't. But it can also be. We don't want it to be dismissive either.
But I think accepting transitions in life, and when you're 50 or 55, you're not meant to feel the way you did when you were 25. And there's an acceptance of that, and also, embracing and making sure you're doing that as gracefully as possible.
That really comes up around weight,
right,
and around skin. Look, aesthetics. Those women. Some women have a really hard time, accepting some of these normal changes, and then when can we do something about it, and when ought we to do something about it, is a matter of more conversation and investigation.
Well, Dr. Hudson, I feel like we could talk for another hour.
We could keep going. I know we should schedule part 2. Yeah,
we should schedule part 2. But I want to thank you for your time today and just wisdom and sharing. You have such a depth and richness of experience that I'm really grateful for you to share that with us on the podcast today.
My pleasure. Thanks for having me.
Yeah, I want to pitch. You have a seminar series, the Institute for Women's Health and Integrative Medicine.
Yes.
Did I say that correctly?
Institute of Women's Health and Integrative Medicine.
I was close. That does quarterly seminars virtually and in person. You have an awesome menopause boot camp that's really well known in the industry. That's one place people can learn more about you. What do you know the website handle for that? We can drop in the show notes.
instituteofwomenshealth.com. And by the way, now they're just all virtual.
All virtual. Okay.
Yeah.
Fabulous. And where else? I mean, you have a Women's Time. People can find that's in Portland, Oregon, if you're looking for clinical care and you're in that area. And any other
my blog, drtorihudson.com.
Fabulous. Well, thank you so much for joining
me.
We'll put those links in the show notes so people can follow you and continue to learn from you, as we have been for quite a long time.
All right. Good to see you. You are terrific and wonderful and awesome and smart and beautiful as usual.
Thank you. That means a lot, Tori. Yeah. Thank you to all of you who listened in today for this conversation. If you want to learn more about hormones and hear from wonderful experts like Dr. Hudson, we encourage you to follow us at Dutch Test on all of these different social platforms. And also be sure to follow and subscribe to our podcast wherever you listen, the Dutch Podcast. And we release a new episode every Tuesday. Hopefully, I will see you next Tuesday. Thanks a lot. See you soon. If you're wanting to learn and really expand your expertise in hormones, you're not going to want to miss our podcast. So make sure you tune in each and every week for our new content.